Hello, everybody. I'm Abdullah Alassiri, cardiac surgery house officer at King Abdulaziz University Hospital in Jeddah. Today, we will be talking about the factors affecting the outcome of ECMO post-cardiac surgery. I have no disclosure to declare. Regarding the introduction, extracorporeal membrane oxygenation is a technique for the long-term treatment with patients connected to a bypass. ECMO support is achieved by draining the venous blood and taking the oxygen and resupplying it with oxygen. The first successful use of prolonged support was by Dr. Donald Hill in 1971. The first use of ECMO in a neonatal patient was done by Dr. Bartlett. She is currently living. She's called Esperanza. You could search through it through Google. She's currently 45 years old. There are many subtypes of ECMO. We'll be just focusing what we will be doing in this study, which is the VA ECMO. It provides support with cardiac failure. And in our study, we use the central VA ECMO. Those are pictures of the VA ECMO. So as it's a Gulf conference, I just talk briefly about the current status of ECMO. In the left figure, it is published in 2017 by the SWAC also, showing the number of centers in the kingdom. And the right figure, it showed the current state of ECMO in the Ministry of Health. From 2014 till 2019, we only provided 3 services, but post-COVID-19, it increased and reaching up till 23 services. So this is a satellite map showing the ECMO services in the Gulf region. So what are the objectives of our study? We wanted to identify the predictors of survival of children requiring ECMO post-cardiac surgery. We also wanted to report the results of ECMO support after the repair of congenital heart defects. We retrospectively reviewed the patients in the 3-year study. We took the hospital admission records, operative records, and perfusion data. We have 2 definitions and 2 endpoints. The first one is successful decannulation. It is defined if we removed successfully after 48 hours. Survivors are patients who reach till hospital discharge. So it's a single center study. I come from this beautiful city, Jeddah. It's located in the western region of Saudi Arabia. The study was done at KAU. So during the 3-year period, we did 746 pediatric patients who required congenital heart defects. Only 30 patients required ECMO post-cardiac surgery, representing only 4% of the total sample size. The patient's age ranged from 1 day till 20 years, with a median age of 6.5. The median weight was 5 kilograms, ranged from 2 till 53. So regarding the location of ECMO insertion, we insert the ECMO 16 times in the ICU, 14 times in the OR. The indication for ECMO insertion, the most common was failure to wean off cardiopulmonary bypass, followed by ECPR and low cardiac output. Regarding the pathologies, most patients who required ECMO were single ventricular repair patients, constituting 18 out of the 30. The clinical outcomes, we successfully decannulated 20 patients out of the 30, and only 12 patients survived till hospital discharge. So what were the ECMO complications? The most common ECMO complication we had was renal insufficiency, followed by the liver dysfunction. Hemofiltration was required in 20 patients, and 5 of those 20 required hemodialysis. So what are the possible risk factors for hospital mortality? As you can see in green are the patients who survived. Single ventricle showed slightly significant favorable outcomes with 0.058, having lower serum creatinine levels. In addition, lower ALT levels showed better survival rates. This is a Kaplan-Meier curve showing the survival rates. In red, it's the biventricular patients with more survival rates compared to blue, the univentricular patients. We reclassified again using the RAC score. Not surprisingly, having 5 and 6 RAC score was associated with more mortality rates. The non-survivors required significantly higher colloid transfusion rates during the second day, most likely due to the capillary leak that happens during the ECMO. So what are the factors associated with successful decannulation? We only identified 3 factors: age, body weight, and ECMO flow rate. Having higher age and higher body weights was associated with more successful decannulation, and reducing the ECMO flow rate in the first 4 hours was associated with more successful decannulation. So what are the conclusions? Application of VA ECMO in selective patients has a definite survival benefit. Early initiation of ECMO before renal and liver impairments was associated with better outcomes. Survival to hospital discharge was better in patients who underwent biventricular repair than univentricular. Capillary leak on ECMO could be a risk for mortality. Those are my references. Thank you, everybody.